and welcome to the Alabama Public Health Training Network. I'm William Kennedy, State Social Work Director at the Department of Public Health here in Alabama. Thank you for joining us today for our program, Ethics in a Post-COVID World, New Challenges and Familiar Solutions, Part 2. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email are on your screen now and will appear again later in the program. Also, the handout, sign-in sheets, and evaluations are available online. I know we've had a couple of messages saying they weren't available earlier, but they are now available online. You'll need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheets and evaluation. While content may remain relevant for up to over 2 years, CE credits only are awarded for 2 years for nurses and social workers, expiring on June 16th, 2024. If you are watching this program on demand and want to receive a social work CE certificate, you'll need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours, and if you're watching on demand, it's considered non-classroom hours. Before we get started, I'd like to introduce our presenter today. James Sacco is a consultant with the Alabama Department of Public Health, and again, this is part 2 of a 2-part series on ethics. Jim, welcome back.
Great. Well, thank you. Good morning. Morning to everybody here in the room. Good morning to people watching on the video. I'm delighted to be back. For those of you watching, I guess, on demand, welcome back from 5 minutes ago. Hopefully they took a little bathroom break in between the 2 sessions. Today's topic piggybacks on last time. Yesterday, we talked about coming out of a post-COVID world, and what I stumbled over at the beginning, is it post-COVID or almost post-COVID or something? As the request came from the leadership team, it was, let's talk about ethics. And as I thought about it, I thought, let's all try to make sense of where we've been the last couple of years since COVID, and try to remember what we've been through, and frame it through the discussion about ethical challenges. And I said yesterday morning, part of what guided me as I was doing the research for this series was to look at the NASW Code of Ethics and look at what had happened. And in 2021, there was 2 amendments to the NASW Code of Ethics. One that was about the importance of professional self-care for people in the field of social work, and that kind of drove the bus yesterday in terms of trying to think about the impact to all of us, psychosocial impact to patients, us, and then talked a good bit about virtual service delivery and the wacky changes we've made in a very short period of time. The second amendment to the NASW code that happened again was ratified in 2021, was an enhancement on the importance of cultural competence. And so today we are going to kind of roll up our sleeves, and as we think about what's not changed, we're going to talk a good bit about inequality, about social determinants of health, and about, in some ways, how, from my perspective, COVID and the post-COVID fallout has been instructive to us about the haves and the have-nots and the challenges all of us face. So that's me. I have a master's degree in social work from the University of Georgia. I always say mom and daddy bought a master's degree from Georgia. I give them credit. And a clinical social worker. Yesterday people asked about my background, and I was a real social worker doing all sorts of behavioral health stuff, and about 20 years ago I met some people who said, we need somebody with social work skills and we'll teach you how to be an educator. So this kind of unexpected career fork. I always say I'm usually in the basement of some county health department somewhere, having stopped at the Waffle House on my way there, and anyway, it's been an interesting ride, and I feel grateful for all the frontline public health people I've met. It's been an incredible career. So those are objectives today. My first objective is to keep you awake for 90 minutes. That's always critical, especially those, I guess to those watching on video, try to keep them off Zappos or Facebook or Instagram or the other tantalizing things other than me that are there on their computer. But really, we're going to talk about, again, yesterday we talked about challenges with telehealth. We talked about what happens when we go back into the reality. Today we really are talking about, as I said, the importance of understanding difference, of addressing diversity, and for all of us as nurses and social workers to be concerned about issues of inequity. So this slide's a repeat from yesterday. It's new to people who are just here for the first time. Cindy's just seen it for the first time. So again, what our code of values as social workers is about. And again, obviously, competence, but for today's training, what that also means is not just the ability to provide competent service, but if you drill down, what the code says is to provide services that are competent in respect to working around difference. And I've got language in an upcoming slide, but its importance, obviously, competence as a social worker is important, but the standard goes on to talk about working with people around various diversity, and that's really, again, at the heart of why we're here, and I think it's at the heart of why NASW leadership said, let's really put some muscle behind the code of ethics and really reinforce the importance. Service to others, obviously, it's what we do. Social justice. I debated how far to go today. But we can't just talk about individual social work practice. And I think as social workers, we are charged to advocate. We are charged to think about social change. And in preparing for this workshop, I found myself just looking at inequity in this country around race, ethnicity, economics, rural versus urban. And, frankly, for me, it calls to mind the need for all of us who are social workers, and you'll see in just a minute the nursing code says the same thing, to think about the have-nots in our culture and to think about whether they are have-nots just because they are lazy or not deserving or not something enough, or if the system that we've created that people have been born into reinforces inequity. And I'm gonna start at 9:05 and say I think there's something about structural inequity that comes up for me as I prepared this, and I just want to name that. And if people want to tune out of the video, they can tune out now. But I think as social workers, and like I said, as nurses, we've got to think about these big issues and ask these hard questions. Dignity and worth of individuals is at the heart of what we do, the importance of human relationships. And integrity means acting, I think, in ways that are true to our professional guidelines, including the ethics. So yesterday I talked about the nursing ethics, and I hope I didn't offend any nurses. I got one in the room by saying I was a little surprised at how close the nursing code of ethics aligns with social work ethics. Protecting human rights, health diplomacy, reducing disparities right there in the ANA nursing provision. Principles of social justice right there in the main provisions. So everybody step back with me. Kind of think about where we've been, the state of the country. It's exhausting to do. I want to just say that sometimes it feels exhausting to look at where we're at as a nation, as a culture. And just think about these questions as you look at the globe, as you look at the great state of Alabama. Where are human rights concerned? Where do human rights concerns exist? Where do you see health disparities affecting Alabamians? And do you think there are do you see issues of social injustice that we as nurses and social workers should be concerned about? Anything come to mind as I ask those very hard questions? I'll start. It's hard. These are tough questions. I'll start. Certainly, what we know is Alabama, like everywhere in the country, has poorer health outcomes for people of color. That if you look at cancer survival, hypertension, there are a number of diseases where the outcome in terms of life expectancy, quality of life is poorer for people of color in Alabama. Multiple health conditions where there are disparities around race, ethnicity. That's been true for a long time. The bad news is we've not closed that gap in the country. We've not closed that gap in Alabama. And so again, these questions of why disparities exist and the really thorny issues of what to do about it. What else do you see as issues of human rights, health disparities?
You know, here in Alabama, it's urban versus rural,
Yeah.
And so access to care
You bet.
is a huge issue, and it starts with at the earliest stages of life with access to the women that are pregnant and having health care
You bet.
during pregnancy, and goes all the way to the end of life.
Yeah,
And
yeah.
so access to care versus rural versus is urban.
You bet. You bet. And I like what you're saying. You're a true social worker across the lifespan. From does an unborn baby get better or worse prenatal care up to end of life? And yeah, absolutely. That access to care, distance to services, absolutely an important concern for all of us. Other folks, what are issues of social justice and human rights in Alabama? Anybody have any thoughts?
To take it a step further, access to insurance.
Yeah, yeah,
So
yeah.
we see that across the state as well,
And
in a variety of different professions that aren't covered, working 40 hours a week, but yet have no insurance or access to insurance.
Yeah.
And so very fortunate in Alabama. Our CHIP program have some of the highest percentages of children that have health care insurance, but our adults are lacking.
Yeah, yeah, and Bill, that's great. The difference between the haves and have-nots around health insurance access, I'm going to challenge everybody and take it a step further. What about income inequality? You know, the reality is that if we talk about people in the service industry, we're going to get there in just a minute. They are disproportionately disadvantaged and stuck, and the connection between level of education and opportunity and economics is a pervasive problem. Part of that rural-urban, part of that is just people get stuck in the social class they're in. And is that people are bad or lazy? I don't think so. It just means if you are born rich in this country, you are likely to stay rich and likely to have a lot of advantages. And if you are born poor in this country, yes, we all know somebody who rose out of it. And the deck is stacked against you for a number of reasons. If you look at the outcomes for people born into poverty, Cindy, am I lying? Send me home if I'm lying. You've seen it. That the reality is breaking the cycle because of a lot of, I believe, structural things is something that we just need to name. We just need to acknowledge part of this difficult conversation. Anybody else? Injustice, health disparities, human rights.
I mean, right now it's a hot topic, not just here, but everywhere. I think about the healthcare ban for trans kids.
Yeah. That the issues for LGBT people, trans kids, and you know, let's not let people use the bathroom they want and play sports the gender they want. A movement away from marriage equality. I think, I think we're in a bit of a backlash, and that, you know, I guess that's the nature of the political continuum, but that certainly, I think, for lesbian, gay, bi, trans kids, and I always think of a friend of mine who has an 11-year-old, set of 11-year-old twins, born 2 boys, now 1 boy and 1 trans female. And it's heartbreaking to think about a woman who loves both of her kids the same, who's doing what she can, but lives in a world where one of her kids faces a whole lot of barriers You know, it's interesting because they're twins. You see the road of the cisgender boy having a pretty easy road, and you see the road for her trans daughter, and it's a lot different.
Our disabilities population.
Yeah, you bet.
We've done a lot of work with that population in the last couple of years, especially related to COVID and vaccines and access to care, and so transportation continues to be a huge issue. Housing continues to be a huge issue. That's accessible, affordable, and all of that kind of plays into healthcare.
Yeah, my sister works at a disability advocacy agency, and man, she'd fill up the hour, brother. I tell you what, with what's not right. That we've got ADA and we've made some strides, but her take on the world is there are structural disadvantages for people with disabilities. Folks, I'm going to name two that are hard to talk about. One is racism. And structural racism that exists across our country, and that I think is very difficult to dismantle. But I was thinking coming over here today that every single African American family I know has had to have a talk with their adolescent boys about how to act if they encounter law enforcement. And none of my white friends have ever had to have that conversation. I'm going to call that racism. And I'm going to just say if you were paying attention, we saw George Floyd murdered after he was captured. And it sort of reinforces the need to talk to young African American men about being careful. And the last one is about the right to vote. You know, this is America, and in your neighbor state, let's pick on Georgia. Why don't we pick on Georgia? Your neighbor state passed a law after making it illegal to give people water who are standing in line to vote. There's a law that makes it illegal to give people water because I believe there's something about who's voting, and a structural. I know because I know the voting sites in Georgia, having lived there 30 years. There's a structural way in which certain sites make voting easier, and certain sites make voting longer and harder, and that is about people of color and people who vote a certain party. I hope I'll be invited back to the Alabama Public Health Training Network. But if not, it's been a privilege, and I'm not doing my job if I don't ask these hard questions. So what we're getting at, and I do not have the answer, but as we talk about what's behind the NASW code enhancements, what I think should be challenged about as social workers and nurses wrestling with our ethics is this connection between political, social, and economic inequality. It's what we're dancing around here. The bill talked about people less insured. That's about the economics of that. You talk about people with disabilities. I promise you the vast majority of people with disabilities are in the bottom 20% of wage earning in the country. And so again, if you talk about what happens when you are in that lower socioeconomic status and who gets elected and what the cycle entails, there is just an increasing sense, I think, of pessimism among people who are lower socioeconomic, who are racial and ethnic minorities, who are sexual and gender non-conforming, that says the system doesn't work in their favor. Maybe the system is stacked against them. And again, I'm asking these hard questions. This is Yeshiva School of Social Work 2019 study, polled social workers. So if you hate social workers, blame social workers. I tend to think there's some smart ones. I got 7 smart ones, 6 smart ones here in the room, and asked what are the challenges that we social workers should be facing in terms of social justice. Voting rights was at the top in 2019. That this systematic way in which a number of states are trying to make voting harder, systematic way in which a number of states are trying to make voting harder for, I think, people of color, poor people. It was the top issue. Climate justice, which does have to do with poorer people, the people who are suffering, people who have more difficulty surviving issues of climate change, tend to be poorer people of color. Access to health care, bills on it. Refugee status, we didn't talk about, a country where, the Statue of Liberty still says, give me you're tired, you're poor, I think. Thank heavens, because my grandpa came over when he was 1 year old. I guess I'd still be in Italy. On the other hand, maybe, it wouldn't be all bad being back in Italy. But it's a country that welcomed my grandfather in 1902. I'm not sure it's the same country. And it speaks to what our values are as a country. Do we still say that? Or is building the wall? Yes, I did. It's building the wall. Our priority: racial injustice, economic and gun violence. I do not. That's a whole other video conference for somebody smarter than me. But what do we do about living in a country where we seem to be accepting somehow that few mass shootings a month? I can't even count how many we've had. It's acceptable that that's okay. And then access to food and access to healthy food. I was down in, I say Mobile, but that makes it sound whatever. Bayou La Batre, where I was early in the week, which is different than Mobile, brother. I tell you what, they're still wrestling alligators down there in Bayou La Batre, and talked about life in food deserts and good people with the Wise Woman program trying to carry fresh vegetables to people in parts of the state where just having access because they're in a food desert is harder. So all kinds of reasons. Let me pause. Questions, comment. There's a slide somewhere. You have the ability, if you're watching on demand, excuse me, to send questions or comment through the email address. You can call in directly. In the room, comments. If I'm off base, please jump in and let me know. Any comment, any questions? I need a drink of water.
I thought it was interesting that it's 2019, your list there, and I would dare say that all of those are still in the top however many you had there, but I would dare say that they've probably shifted some. Gun violence has really been a topic in the last couple of weeks, last couple of months. Food scarcity continues to be an increase there. But all of them are still still very
sort of what I'm looking back at the slide. What things have changed as a result of the events of the last 3 years, and what things might have shifted as a result of COVID.
Right.
I would imagine it's still the same 8, but I think you're right. I think there probably have been some changes. And so as I said, the reason we're here, the reason why this topic of diversity and understanding how to respond to cultural differences is important is our professions tell us that this is an ethical issue. I said this 2021 update to the NASW code talks about our need to develop knowledge that guides our practice. And again, taking action, this last line, it feels like a lot. I'm just going to keep it real. It's like, I don't know y'all, but it seems like, boy, if I just fill out my paperwork by 4:45, it's a good day. But oh wait, you can't just fill out your paperwork. Make sure you address oppression, racism, discrimination, inequities, and acknowledge your personal privilege before you punch out for the day. I do think, again, what I learned in social work school early on was we are charged to advocates for people who are have-nots. It's the reason why I didn't get a degree in counseling or some of the other professions. Social work felt right to me because I do think, and people ask me where I learned it, and I really credit my parents who were not showy about it, but who lived a moral life, who were people. Mother was a nurse, my parents were churchgoers, and they taught us something about the obligation of caring for people who were not as privileged as we were. And so I can't do these things all the time, but I like the idea that our profession says, hey, we have to look at these really scary things. We have to be willing to do that. And then obtaining education. You're here, not only do you get CEUs, but you get to check off this box. You're obtaining to understand the nature of social diversity and oppression. And again, this cycle of social, political, economic with regard to race, ethnicity, national origin, color, sex, sexual orientation, gender, identity, or expression, age. Nobody talked about how hard it is to be old, Bill. I tell you what, I got achy bones here and there. Talk about the economics of our elders. I mean, that's a whole other class, but you could do 90 minutes just talking about what it's like. And again, talk about, what COVID showed us, not only the disproportionate impact, but the lives of some seniors are pretty troubling in the richest country in the world that we've got. Older people living the way they live. Political beliefs, marital status, immigrant, mental and physical ability, to Bill's point. So again, the code challenges, the update says demonstrate understanding of the nature of diversity and understanding the oppression that people with those differences face, and aware of cultural and socioeconomic differences among clients who use and access electronic technology. Yesterday, we talked about technology, and what we sort of touched on, but we didn't say out loud, is everybody doesn't have the latest version of the iPhone, y'all. And if we talk about who was able to jump into the telehealth world and do that more easily, and able to use technology to keep appointments or stay on their psychiatric medication or whatever else, again, I would argue that there are people who had some advantages, economic advantages, who were more able to jump into the electronic age with us than those who did not. I don't know. I've not tried it, but I'm assuming trying to get onto Zoom with your flip phone, track phone, burner phone that you got for $89 at the corner gas station, probably not as successful connecting as the latest, smartest version of the iPhone, Samsung, something or other. Social workers assessing issues that affect the delivery of these services. And I think we touched on this yesterday. Please.
Yeah, so we talked about, just earlier, we were talking about barriers, and so that rural barrier, often our rural communities, the broadband is just not what it is in the urban, and so we talk about the potential for telehealth, telemedicine, but access to care includes lack of broadband,
you bet,
so that you actually have access to great hospital, UAB in Birmingham, world-renowned, great doctors there, and yet here just a couple of hours away, trying to get access to those doctors is a challenge.
It's a great, thank you, Bill. It's a great story, and I wish I remembered the county. You guys may know, but it was a story. It was on the national news, the Washington Post, probably. That's what I read. But a woman in, down Selma Way, somewhere down there, drive an hour and a half out there around COVID vaccination. She was like, people are not going to be checking their email and their website down here. So what she did is she set up a text network, and she was advocating, I'm going to say this name because it's at the Dollar General. She was doing a health advocacy thing at the Dollar General, because she said people are going to be at the Dollar General and they may not get their email, and they may not be tapped into adph.org, but I'm going to find them at the whatever. And she was encouraging vaccination and she was not employed by ADPH. She was just a concerned community member who said, if I'm going to keep these people alive in my community, I'm going to work the Dollar General and work the parking lot here and tell them where they go and I think some county health departments set up some outreach and was doing some vaccine. Anybody know the county I'm talking about? Like I said, I'm embarrassed that I don't, but it was just one of those great stories.
It was over in the Marengo Greene County area,
okay.
Sumter County,
But
somewhere.
just one of those things of like, man, that's how it ought to be. That's what we need to do.
We also saw it down in the Bayou La Battery area.
Yeah.
The health clinic down there was really pushing the vaccine, and so we saw some good
and addressing those barriers. Again, I was training early in the week. I said, well, yeah, great, you got me an appointment. Let's use UAB. You got me an appointment 2.5 hours away at UAB or however far I live, and it's the 27th of the month, and we got $4.75 left, and I got kids to feed and $4. And well, yeah, it'd be great if I went to that specialty appointment down there at UAB, but parking is $3, and there's no gas in the truck, and and again, for those of us that are able to jump in the car, jump in our SUV and drive over to wherever they want to make an appointment for us is a different world. So how do we know we're doing our job well? Again, this is back to the NASW code and our guidance. And again, I think it aligns nicely with what nurses have been told. It starts with self-awareness. And I really, as I read the guidance, I thought, again, I was glad to be a social worker. And I thought, you can't really come to this without saying, what's my history? Sometimes when I teach a whole day, what I say is remember the ghosts in your life. What did your grandparents tell you? What did your parents tell you? What has your life experience told you about people like you, about people different than you? And so just sort of acknowledging, and I think to do that without judgment. One of the things that happens in this conversation is people can be divisive and say good or bad, or your beliefs are good or bad. I think this self-examination comes with the best form of this self-examination is just to be curious, to sort of understand. Your grandparents came with their own biases from their parents and their grandparents, but we take it we bring it with us. I think, particularly if we haven't examined it and decided. Being aware of privilege and power, and I got that early on in school. I'm glad to report that in my preparation, there was talk about remembering the power imbalance, and we forget that because most of us don't come to social work or nursing on a power trip. But the fact that we have a diploma, that we have plastic tags around our necks, that we're perceived as the expert, inherently sets up a kind of power dynamic. And the fact that we did sleep indoors last night, that we do have access to food or health insurance or whatever advantages we have, those issues of power and privilege are things for us to acknowledge, again, not from a lens of sort of self-flagellation, but just to say, as I prepare to best meet the needs of these clients who are different than myself, who have these barriers to service, I think it's really important to kind of say there's some really powerful differences to acknowledge. So doing our work to develop knowledge of history, traditions, values, of others. I think what's really important is that we do that in ways where we're not exclusively reliant on our consumers to do that for us. The criticism is, yeah, if you're in a session with somebody and want to say, hey, help me understand the values of Hmong families, let's go back to South Alabama and help me understand how people from Laos or Cambodia think or feel, but that ultimately the work really is for us to do the work on our own, and the burden becomes us as nurses and social workers getting educated and not relying on our racial ethnic minorities, our refugee, our people of color, our gender non-conforming. We're doing that work ourselves. We're getting education where we're doing the work to get there. Use a broad range of skills to demonstrate the importance of culture. Knowledgeable and skillful in our use of services, resources, and institutions available to serve multicultural communities. I mean, again, we do some self-reflection. We gather information about working with people who are diverse populations, and then we act in ways that are appropriate. So I want to talk to folks here in the room. What's been helpful to you in terms of becoming more culturally competent? Just in a broad sense, are there ways, experiences you've had that have helped you benefit, have benefited you in delivering services to diverse people? Look at your own professional journey. Are there things that have happened that you've done that have been helpful? Anybody, any thoughts about what's been helpful to your professional growth that you're willing to share?
You know, I've had a couple of colleagues that don't look like me that I have been able to communicate with openly and non-judgmental, and so
Help me understand.
Yeah, and,
Absolutely.
and I think it's been a two-way street. And so that's helpful.
Absolutely, absolutely. The ability professionally to work with people, beside people who can help us grow. Other things you found helpful in your journey. Anybody thoughts about how you've grown as a professional?
I think just the more exposure maybe you have to different populations, different anything different would of course increase awareness, increase that like self-awareness as well. So just the more experience and more exposure you can get with diverse populations.
Absolutely. I think about the first time people said, you know, I've done a lot of substance use. First time people, here's how much substances I use, and you go, wow, my goodness, who uses that much? And now, 30 years in, I'm like, well, of course you drank a gallon of vodka, doesn't everybody? Whatever. It's just like what was new and shocking, and there's something about. And a willingness, I want to take it a step further, there's something about empathy. It's like, well, I want to understand your life experience, and so it's being there, but it's being there with a sense of empathy. Like, I want to understand. I define empathy as understanding the feeling level experience of your patient. So if we're there, if we're with people different than us, and we're really working to be in their shoes, we're going to come along. We're going to get there. It's less shocking, different, till we become more competent. Other thoughts, back road? Ways you've grown? Anything anybody wants to add?
I think, at least in doing child welfare work, something that was really helpful for me was being able to spend as much time as I did in homes with families.
Yep. There's something about seeing it. Mm-hmm. I'm smiling, Cindy, one of my very favorite stories ever. I was training in rural North Carolina, and school nurses were in some ongoing training with me, and they had a colleague, an English teacher, who just couldn't understand why these children couldn't finish their homework, and what's wrong with these children, why ain't these parents blah, 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 right? Blaming the parents, blaming the kid. And the social workers were out to do a home visit, and they put her in the car. They said, come on, Heifer. I hope they didn't call her that. They said, come on, Heifer, we're going for a drive. And put her in the car, took her on their home visit, went in the house, did the visit, came back to the car, closed the doors, and the English teacher says, looking straight ahead, I had no idea. And it was like, you talk about the difference between I'm an English teacher with privilege who can't understand why my assignment isn't the most important thing, to I'm a mama who's got a tarp over my roof and they're about to cut my AC off, and squawking kids, and grandma fell and broke her hip, and I'm trying to make do. I'm cleaning rooms at the day's end. I'm trying to keep it together. But boy, when you that bougie English teacher, ain't that the most important thing, that homework, the whatever, kind of whatever. Yeah, so there is something about seeing in real life that gets us away from judgment, I think, gets us closer to understanding and the circumstances. Again, that web of inequality is not just an abstract. It's I would argue when we see some of the people who are struggling, they're from struggling people, that they came from struggling people, and best hope we can have is maybe that their kid's going to struggle a little less, because it's tough. Where they live, the systems they're born into, the economic reality. So again, I love what we're saying. We do grow professionally, we in this guidance, we do our self-assessment. You know, I didn't hear formal training. As a formal trainer, I have to say, go see a trainer, but a role for formal training. But what's interesting is the informal things you described. Meeting other people, meeting families, opening our hearts and ears to clients. Bill, you want to get in?
Well, social media has been really good, especially the last couple of years. I've seen several shows, I guess you call them, on Facebook or whatever, where different groups talked about the difficulties. Our Alabama Medical Association had weekly or every other week talks in the afternoon on Thursdays that were really good, and I know I think there was a women of color, doctors of color, that talked about challenges they had.
Beautiful.
And then my advocacy groups, my disability advocacy groups have been real good about doing some different, and you know, that's such a large population, it's got a lot of subpopulations to it, so there's a lot of different information I've learned there. But
that's great, Bill. Training is not just drive to a building or even fire up adph.org. It is using our media to just, and if you like one thing, it's going to lead you to some other good stuff. But there are lots and lots of people in this business of advocacy, in this business of helping us pay attention and wake up and learn about the unmet needs of patients we're serving. And if we're paying attention and we're smart, we can tap into those resources and good organizations, good people. I'm trying to not plug my sister's agency in North Carolina. Anyway, if you're watching, there's some good disability advocacy groups in North Carolina. I can't name a particular one, but there's some good ones there. So those who are watching, if you want to get in the conversation, there's a phone number scrolling across the screen. We welcome any comment or questions from people who are watching on the video. Bill, do we have anything from people yet?
We don't.
Emails? Okay, feel free to email if you'd like. So we sort of talked about this internal journey, the journey of the individual nurse, the journey of the individual social worker. You know, for those who are scratching their head and saying, well, how does this relate to my job? How does this relate to public health? I really wanted to drive this home and kind of make this connection between issues of social inequity, the need for cultural competence, and addressing social determinants of health. Again, what I said earlier when I said what's going on here in Alabama and pull back going on everywhere in the country, certainly everywhere in the Southeast, is this difference in health outcomes for people of color. That brings us to the question of social determinants of health. This is a definition from the World Health Organization. Is this familiar to people in the room, social determinants? Are we in this conversation, kind of, sort of? The idea is that where I'm born, grow up, where I live, where I work, and my age is going to affect my health. And studies that say because of all kinds of issues we've started to talk about, that my socioeconomic status, my education, my neighborhood, the physical environment that I'm in, we didn't talk about any place yet where who lives near the dump? Who lives near the dump? Who lives somewhere in South Alabama where there's chemical plants making chemicals? And what the environmental, I'm guessing that the best real estate in South Alabama is not next to the chemical plant. I'm guessing the people that are downstream of the chemical plant are probably disproportionately poor, disproportionately economically disadvantaged. And so, just sort of thinking about, and Bill raised not only social support, but access to care, like how I get from here to there.
You know, Jim, a couple of years ago, you did a training for us on substance abuse, and talked about the pain medicine that was being dumped on in Alabama, and specifically in our coal mining communities. And so, a long history of taking advantage of this group.
You bet.
And so.
We see the problem of opiate use down the Appalachian Trail into North Alabama. We had a great woman come over from UAB, or no, she was here in town.
She was from mental health.
Who came down and talked about opiate substitution. But it certainly is a problem disproportionately affecting people who are poor, people who are rural, people who have lacked access. So the connection here between disparities and social determinants, the idea here is that health disparities exist when I have difficulty, when there's differences in the incidence, prevalence, mortality, and burden of disease. And I want to drive this home. As I said, here's a set of examples. This is an NIH paper on social determinants. Incredible disparity in Alabama, across the southeastern United States. African Americans disproportionately impacted by HIV. And that is about access and all sorts of other complicated issues. But last time I looked at the statistics, the prevalence by race ethnicity of HIV in Alabama was twice the general population statistics. I think I'm going to go on a ballpark, 30% of the population is African American, more than 60% of cases of HIV African American. That's true all across the southeastern U.S. That's Mississippi. That's definitely Alabama. It's definitely Georgia. It's definitely South Carolina. That disproportionate impact. Most places twice the rate of the general population. Infant mortality among Alaska Natives, American Indians. Look at that, 60% higher than European Americans. Obesity, rates of obesity for Hispanic children and adolescents. Heart disease, again, outcomes from heart disease. African Americans, 30% more likely. And again, as we talk about the reality for African Americans, poor outcomes from cardiovascular disease, diabetes, and some cancers. And so, you know, sort of as we're talking about, well, why get better at cultural competence? To me, this cuts right to what we as public health people are about. There's a direct connection from my way of thinking to growing as professionals and being willing to face up and say, we need to address these disparities, that these disparities are real. And what if we learned in COVID what's different and not different? There are people who would argue that COVID shined a light on health disparities, and that in many cases, a lot of studies that say the essential workers, people who had to keep going to work, couldn't go on Zoom, were disproportionately poor, people of color, working class. So this is a JAMA article early on. This is, I think, late 2020, but African Americans, more than 50% of COVID cases in Chicago, 70% of COVID deaths, and they were at that time 30% of the population of Chicago. Louisiana, there's a statistic there as well, 70% of deaths among African Americans. Michigan, 33%, 40% of death, even though black people were 14% of the population. Black counties in the U.S. What is the date here? I'm trying to look. It was late 2020. I don't have the specific date. It was an excellent article in JAMA. These figures did not change much as the epidemic progressed. But again, infection rate more than threefold. And death rate, again, COVID, like other chronic health problems, disproportionately affecting people of color, and higher prevalence and higher mortality. I went back recently as I was preparing for this. What was compelling was, well, let me put it out to people in the room, the worst, again, not hard numbers, but highest prevalence rates and highest mortality from COVID. What racial ethnic group? Anybody want to make a guess? Be brave, somebody. Nationally, the racial ethnic group that had highest rates, prevalence, and mortality from COVID-19. Come on.
Southeast Asians.
Southeast Asians, no. Black, no. American Indians, indigenous people. Way, way high, nearly 60% higher than Caucasian Americans. Again, by actual numbers, not as large, but the biggest impact. And again, if you think about the life of indigenous Americans, poorer, rural, access, other chronic health conditions, higher rates of substance abuse, always higher rates of infant mortality. And here we are again, COVID sort of shining a lens on holding up a lens about what's not here. Outcomes for Americans of color, Latinx persons, various states, just higher rates of HIV among Latinx persons. You see the numbers, so I'm not going to read numbers to you. Just a note, Hispanic, Latino, Latina have been debated. I think the preferred language to talk about people is Latinx, which is more inclusive. So if this isn't familiar to people, its language, I've been told, is preferred. Another illustration, I just put it out in terms of what's going on in America, is what happened early on. I don't know if anybody remembers this, but in the spring and summer of 2020, if you were tracking national cases, there'd be these weird bubbles in the middle of rural nowhere, of clusters of COVID. We saw New York City, we saw Seattle, we saw Atlanta, we saw Miami. All of a sudden, we're down here in Smithfield, North Carolina, and I'm looking, what's up with the hotspot? The language CDC was using was hotspot. What's going on in Smithfield, North Carolina? I hope Smithfield hams don't sue me because they got a lot of money and plenty of lawyers, but I'm just telling you what the facts are. Smithfield, North Carolina was a pork processing plant. And what happened in a number of these hotspots was that there were food processing people, which are disproportionately immigrants, always less educated. Again, we used to think of poor white people, then Latinx persons, increasingly Asians and African immigrants, now slicing our bacon and chopping up our chicken breast, but 40% foreign-born. Historically, always difficult work environments. Poor history for workplace history. There's a 1920s novel by Sinclair Lewis. Mm-hmm. It'll come to me. Google it. Everybody got their pull out your smartphone if you're curious.
Jungle? The Jungle?
Something Jungle, yeah. Is it just The Jungle?
I think so.
Yeah, Bill got it, Jungle. That documented the 1920s, an awful work condition. It hadn't changed that much. Pressure to produce and do more. I saw pictures in the news. They saw these outbreaks. They saw people falling over on our bacon while they were trying to work, and they kept them working 12-hour days and whatever else in these cold, wet environments. And I saw pictures where they put a sheet of cardboard up between workers. So I'm chopping bacon here, she's over there, and somebody taped up a piece of cardboard as the PPE to keep me from getting COVID. That was the strategy. There's your average wage, North Carolina wage, $13.74. I looked up Alabama wage. It's just about the highest median wage in this field is about $15, almost $16. So again, this was September 2020, but I look at this and I think, well, yes, I like bacon on a biscuit. I got to tell you, I love bacon on a biscuit, and I like pork chops. But what happened is we said these people can't go home because we like bacon on our biscuit and because we need pork chops. And we're willing to, somebody somewhere kind of said maybe we're not going to look that hard at safety conditions. 150 of the largest meat processing plants were in the top 25% of U.S. counties for coronavirus. So again, we'd expect Birmingham, we'd expect Atlanta, we'd expect Chicago, whatever else. We were not expecting these teeny little whatever else. 3,500, this was September, 3,500 confirmed cases, 17 individuals died. This was early on. A plant in South Dakota. Boy, I'm going to get sued. Well, I may end up in jail. Well, I guess it's just a fact. How can you sue somebody who's just giving you the facts? 900 COVID-19 cases in a plant with 3,000 employees. So it's the work condition, and then it's also the living conditions. Anytime you've got workers in this kind of low wage kind of stuff, it's 8 to a room and bunked on top of each other, and there's no social distancing. Please.
Just to tag on to that, here in Alabama, we work real closely with our chicken plants.
The same thing.
Alabama is one of the largest chicken processors in the nation, and so that was a issue that we worked through, and some of our vaccination clinics were specific to those areas to try to help.
Yeah, but higher prevalence of COVID in those places,
Definitely.
Bill? Yeah,
Yes.
absolutely.
It's the closeness of the working
You bet.
situation.
Closeness to the work, ways that people live, the fact that the work could not be done social distance. There just wasn't enough PPE for people to do that safely. And there you are. So I looked at, this was a recent study, I think this came out in April, that just kind of looked at who died. I think it's who died in the first year. But again, it sort of speaks to all of us about health, about social determinants of health, death rate, and again, how social determinants of health affected the outcome of COVID. The death rate of lower socioeconomic position adults, didn't go beyond high school, 5 times that of higher socioeconomic level adults, 5 times higher mortality rate, 2 times higher for intermediate social income. White women made up the largest percent of higher socioeconomic positions. By comparison, 60% of Hispanic men were lower socioeconomic. So that's sort of how it went. But what we saw, and think about it, who was still working in March, April, May? What were their working conditions? Did they have access to PPE? You know, again, I'm glad there was chicken in my grocery store in April of that year. And at some level, I say, as a social worker, as someone who's concerned about issues of social justice, where was access to PPE? Where was access to good information? We didn't have a vaccine then. And again, I'm glad to hear ADPH was part of offering immunization early on. There's a lot of people for whom that wasn't true in essential industries. Death rate among Hispanic men, 27 times higher than high socioeconomic white women. And among all 25 to 64-year-old adults, about 1/3 accounted for 2/3 of COVID deaths within that age group. So this study, looking back at death rates, just reminds us about the reality of social determinants of health and the reality of privilege. And this quote was in the JAMA article. This gentleman is faculty at the University of Chicago, physician, I think a cardiologist at the University of Chicago, but in the editorial that started that JAMA article that I referred to earlier, he talked about privilege, and I used that term earlier. This last line stuck with me. Consider the aggregate burden of at-risk comorbidities to COVID, the effects of social determinants of health, and the absence of privilege is how we ended up with that impact of COVID and the connection between social determinants. I like this slide because sometimes I get this and I say, what can I do about it? How can I, people say, oh, fix poverty, fix whatever else. Like, oh, I'm not sure I can do that thing. I think what I like about this, if you look at those blue circles, if you go from right to left, what you see is the things on the right are things that good case management, good health care, good individual level interventions can affect. We can prevent disease and prevent injury. We can, in our individual interactions, individual level interventions, we can impact risk behaviors. We can check for lead paint. We can do the things that we do. And so it's not the solution to poverty. It's not addressing all inequities. But what I like about this is it says we can all be part of the solution. There in the middle, we look at living conditions. And maybe I can't change that, but can I be part of coalition? We've got important public health coalitions and partnerships where we are working on healthier food programs, where we're working on, is there a walking trail in this community, where we are advocating for alleviating lead paint in particular places. And so we go from those individual level to the sort of community level interventions. And as we keep going about institutional inequities, there are strategic partnerships we can be part of. That is public health partnering with the Department of Education to improve access to health in school settings. We can look at various partnerships, public-private partnerships where public health works with whoever to get access to healthier foods, again, access to recreation, and eventually we may be able to impact these health equities. Again, I think it's easy to kind of say, what can I do about it? But what I think about is, well, we can obviously affect in our individual level practice, and how can we advocate at the county health department level, at our church, in our civic groups. You know, we've got examples all over Alabama of people saying, maybe we're not going to solve poverty, but we're going to partner with people. We're going to join coalitions. We're going to get fruits and vegetables. We're going to do a community garden. We're public health. Somebody's got a plot of land out behind the county health department. We're going to develop a community garden so access to fresh fruits and vegetables is accessible to people in our community. And then eventually, maybe we can impact health determinants. Comments here in the room? Questions here? Anything Letitia, anything I've said that's wrong so far today? Point out all the mistakes I've made so far today.
I haven't.
You know, I know I made some. Anybody, what am I doing wrong? Anybody want to add or ask anything? Bill, any questions coming over the...
None so far.
Okay, no worries. Everybody, if you are watching this on video conference, your questions are welcome, your comments are welcome, and it's a phone number that you can call in as well. So I'm going to brag on my home state here. Let me just go. I'm going to brag on North Carolina, everybody. So North Carolina Medicaid, several years ago, our health director at the time, medical director at the time, said social determinants are affecting the health of Medicaid recipients, and we need to be addressing those. And so what she said, if you look at the scheme at the top, it says the neighborhoods and the built environment. Neighborhoods means where I live, but the built environment means, are there sidewalks? Means, are there playgrounds? Is there access to recreation? Built environment, as I read it, really has a lot to do with health and physical activity. And so what neighborhood am I in? What were the environmental things? And there's hard studies that say if you put bike trails and walking trails in, people are going to get healthier. And if I don't have a place to walk or ride my bike, it's not safe. The built environment works against physical activity and makes it harder. Health care and access to health, social and community context. So in other words, part of what determines my health is, am I in a cohesive community? Am I involved with social organizations? What about education? As we think about the education system and the collaboration, I've got examples of Alabama of innovative, important collaborations between public health and education. Bill talked about some of that. Where that doesn't exist, where the education system isn't involved in promoting health, we see the opposite. And then obviously economic stability, where people have stable economic circumstances, they are more likely to obtain and sustain health. Again, these things promote health. And so what we've done in North Carolina is Dr. Cohen said, you know what, let everybody who provides case management services to people with Medicaid going to ask certain questions. And so it is required. You know it's required, Kelly. I'm looking. You know it's required because the EHR won't let you move on to the next screen until you do it. Does that make sense? A requirement included, not just a requirement, but the EHR will, the electronic health record will lock up until you say, I want to know about whether or not you've got access to healthy food, stable. Do you have access to food? Are you hungry? The question on the screener, and there's a link there. Screeners actually, have you been hungry, gone to bed hungry, somebody in your house gone to bed? It's very interesting. It's sort of an interesting way to ask it, but what about access to food? Do you have stable housing? Is transportation a problem? And then is there a threat of violence? And again, look at the screener there. The screener is much more eloquent than I am, but every provider doing an intake for every Medicaid person in Medicaid case management, not every physician, everybody, but if you're getting case management services in North Carolina through Medicaid, you're asked 4 questions to assess these. And then there are always questions about depression, substance use, tobacco, diet, exercise that are expected to be part of just good health care. So what the system says is, hey, if you're doing a good history and physical, if you're doing good intake, you're asking those things. But in addition to those, you are prompted to ask about food, about housing, about transportation, and about whether or not the threat of violence in your home exists. And there's a model that the North Carolina system puts forward, again, not brain surgery, social, economic, emotional, financial well-being, environmental well-being, physical well-being, intellectual, and spiritual well-being. So the model that they're inviting people to move towards is one of whole person care, the whole person care model. Last slide should have been, it's not there, but what they've done in the Medicaid system is they are referring people to a web-based system of resources that's been developed and maintained by county. Let me back up and show you. So in other words, what it does is it says to the frontline caseworker, I've got food insecurity, I'm here in Buncombe County, and the web system, NC Cares 360, leads you to a web-based thing where I'm going to say, here are the food resources in that county. And again, they've had a huge financial investment. I mean, think about it, to not only get the system changed up to do this, but to get a web-based system of resources that someone made and maintained, but across the state. If I say housing not stable in this county, it's populated with a list of the housing providers in that county. And so I think what's important is it's not only asking these questions, it's equipping frontline public health people with the tools they need to address this, to give them some practical help about that. Questions about the system? I'm not just doing a commercial for the state of North Carolina, but I think the idea that, again, back to that, what we can do in our individual practice, are we asking these questions, are we doing the work to make sure those needs are met, is really something for all of us to look at. So the last thing I wanted to do today was to think a bit about the organizational level. So we sort of have touched on the ways we as individual nurses and social workers grow in terms of responding to diversity. We talked about sort of the intended impact and how we hope it's going to affect public health well-being, or hope it's going to affect health seeking and health care. The last portion of what I wanted to do was to talk about making organizations more culturally competent, enhancing diversity, equity, and inclusion. Let me sort of ask the group here by way of beginning, why would it be important that we ask these questions of the organizational level? Is this organization a culturally competent organization? What does that mean? What would that look like? Why is understanding the cultural competence of the entire organization part of this conversation? Any ideas?
It gives you an overview maybe of gaps in services.
Absolutely. Part of what it's going to do, it's going to invite us to look at service delivery and say, how are we doing? Why else is it important to examine the organization and the leadership and the policies? I'm going to go out on a limb and say, I wonder how, as a frontline nurse, social worker in that organization, how it would be easier if the principles and values and behaviors of a diversity supporting agency were modeled at the top level. And I guess to just name it, how many frontline social workers, how many frontline nurses are working in places where the entire leadership team is white men, where the entire board, most of the board of directors is mostly male and mostly white? Does the leadership, I mean, the first starting point is, does the leadership of an organization look like the worker bees? Does the leadership of an organization look like the clients that we serve? Some places, I think the answer is yes. I'm going to go out on a limb and say I imagine there's some organizations in Alabama, I imagine there's some county health departments where the leadership and the management doesn't reflect who we're serving, and I just think we've got to ask the questions, are we providing culturally competent services if there's a disconnect between the organizations and the people we're serving? Am I crazy? You're not going to say it out loud. Anyway, what do organizations do? I think they do the hard work of thinking about. It's the same steps we talked about earlier. It's doing the work, the hard work of self-analysis. When we talked about the individual nurse or social worker, it says I'm going to do some honest assessment of how we're doing as an organization. I'm going to ask some hard questions, not only of people who like me, who worship where I worship, who look like me, who think like me. I'm going to ask our hard questions of critics, of people that don't look like me, of people who might help me grow. And then I'm going to learn from that, and this shift can be sort of the same thing. I'm going to get, after I do the self-reflection, I'm going to gather information and knowledge, and then I'm going to try to apply that so that, in this case, not just culturally competent services, but a more culturally competent organization emerges. Question, Bill? I say nothing came in.
Well, going back, we were talking about
Please.
Communities.
Sure.
Rhonda Holland has sent in a message.
I know her.
Alabama's cancer program has a shade structure grant for schools and communities with little to no access to community parks.
Great, great.
So, and I know our health disparities grant, we're also working on exercise areas, parks and things where people can get in communities.
Yeah. Back to that idea of built environment. We say, well, what does that have to do? Why is Rhonda lugging turnips and fresh sweet potatoes around to people? That built environment is enormous. And we talk about chronic disease, we're talking about diabetes, we're talking about hypertension, we're talking about heart disease. If you look downstream, if we get people more active, if we build on programs like the SHADE program, did I get it right? The SHADE program, where we are going to have individuals learning physical activity, the advantage of not saying, hey, turn off the screen and do whatever, but actually being part of enhancing parks, building parks, walking trails, biking trails, that all of that, particularly with young people. And back to the idea of partnership, partnering with education to say, hey, public health, we did a grant for 2 nickels. Education, you've got 2 more nickels. Let's go together and enhance the park to, let's use your playground on off times, whatever we can do. But doing that early on to get those habits entrenched early on. Again, health outcomes where the built environment promotes physical activity. There's a direct connection between less diabetes, less heart disease, less hypertension, which I'm sure is why the Wise Woman program is involved. And they know that connection. They are about managing those lifestyle changes. Now, Rhonda Holland's a smart person. Somebody ought to hire her and bring her up here into the big house. Defining diversity. I said the language of helping organizations grow, diversity, equity, and inclusion. Just some language here, defining diversity. If you are promoting a more diverse organization, that starts with the presence of differences in your team, in your leadership team, in the leadership structure. And the question becomes, are you addressing populations that have historically been underrepresented and marginalized in your organization as you move forward? If your organization is to grow into the 21st century, be the kind of organization that we can say is truly supporting issues of social justice and addressing health inequity, that you are doing the things to make sure people who've been underrepresented are part of it. Equity, the second pillar of culturally competent organizations, is about promoting justice. And again, back to the values of social workers, back to the values of nurses: justice, impartiality, fairness, and willingness to look at the root causes of those disparities and say, again, back to that model of how we address those, that continuum from the Kaiser Family Foundation. I'm not sure I can address things on the left-hand side, but I can think about how I'm interacting at the one-on-one level. I can work within my organization, and I can partner with other organizations to grow in terms of addressing social justice and fairness, and try to do what I can. Inclusion. These definitions are from a USDA of all the places. USDA is a wonderful set of materials that I've adapted on diversity, equity, and inclusion. And again, if I'm moving my organization in a way that addresses these unmet needs, that addresses social justice, I'm working towards ensuring that those who are diverse feel and or are welcomed. And so again, we sort of talk about how organizations grow in terms of their diversity, equity, and inclusion, and ultimately, it's not just sort of we're providing services to you, but the idea that there's a full participation in the decision-making processes, that people who are represented, who've been historically not brought to the table, are actually given an opportunity to participate in the development process. So what makes it tough? I mean, I think the history of we've been doing frontline worker bee cultural competence training my whole career, which is many, many years. I don't know many places that have asked the question, how is the organization doing? And so this idea that initiatives around diversity and equity and inclusion are fairly new is important. Like, well, what would that mean, and what does that look like? And third bullet feels important. I think it's true. Leadership lacks diversity in gender and ethnic diversity. And I am a white male, and so I'll say it. We inherently bring privilege as white men to this conversation, and we are disproportionately in positions of leadership across public health, across social services, and that part of making organizations look like us is just making sure that people of color, people who are not European American, and females have a chance to rise to positions of senior levels. I don't know the answer, but as I'm saying that, I'm smiling, thinking, well, yes, there are certainly people in positions of leadership, and who's running what percent of county health departments in the great state of Alabama are being run by European American males. I don't have the number. I think it doesn't look like the people in the waiting room would be my hunch. Kelly, you want to comment? Kelly don't want to comment. Thank you. I'm asking the question. A lack of support at the senior leadership sometimes is lacking. And how we measure this, how we measure organizations becoming more culturally competent is challenging. There aren't metrics or sort of what would that look like. You know, sort of we know it when it's not there. And I guess let me back up and just say there's no ill will about the people running county health departments. We're going to get emails, Bill. You're going to get emails today. I just think I wouldn't be doing my job if I didn't say that addressing social justice, that addressing diversity has to involve asking these hard questions. Does the people running county health departments look like people in the lobby? So what's the value? Why even ask these questions? Well, first we're going to tap into people's real potential. We've got unmet potential that's not being met if we aren't striving towards that. what's the bottom line? Somebody always wants to know the economic bottom line. This is again from the USDA publication I talked about. Better revenue, more customers, and higher profits. I can't say that comes from the public health world, but I don't know anybody running a health department that wouldn't say, I'd like to see more sales, more customers, and higher revenue. And so maybe if we push that. What about employee engagement? And I do think that studies have shown, again, this is from that USDA publication I talked about, that studies have shown that people are happier to work in places that are more diverse. And so what that gets to, and Bill, you've talked about this several times, staff retention. And keeping people on board. You know, people say, I'm losing this nurse. These nurses all want to fly out to Akron and make some real money, or these social workers are hopping back and forth to DHR and back. Well, how are you doing at creating a diverse and inclusive workplace? And maybe that's going to have something to do with staff retention. More likely to understand the consumers with whom you're working. In this case, the language is target customers. I think we don't usually use the term target customers, but maybe we should. Maybe we should start to think about public health like a for-profit business. And then again, that bottom line is about revenue. So what do we do about it? What do organizations do about it? How do we get better? The first concept for us to get is sort of, let's look at implicit bias. This is the unconscious ways that we make assumptions and we sort of project onto situations, our old ideas. And so kind of as we look at not acting on bias about age and gender and race, ethnicity, and people who don't speak English as their first language, we've all got stuff. I mean, what I really find kind of troubling is people that want this journey to sound easy. People say, well, I went to a 1-hour cultural competence workshop and I got a handout where they said all lesbians want you to do this, all Chinese people want you to do that. I said, you cannot put people on one handout, and if you think you got all the answers in 1 hour of a webinar, I'm 30 plus years into my social work career, I still haven't figured it out. And so I think it's this business of examining our bias, of being mindful and not acting on any implicit bias. And again, I just challenge anybody. I don't think anybody ever finishes this work. And I just think that we've got stuff to work on. And it continues into, 30 years into our nursing social work. Understanding what it would be like for others to stereotype you, and sort of back to what we talked about, stepping into people's shoes and recognizing, wow, these are humans and more like me than more different. And then learning to slow yourself down. Talking about characteristics, watching our language and making sure our language is inclusive. If we're not sure about what people of different colors, class, social, trying to find language that is inclusive, and I say always following our customers' leads about language, asking people what language they'd prefer. Back to the issue of gender that Cindy raised, it's like, well, he, she, the sign-in sheet said Bruce, but that doesn't look like Bruce. Waiting, my name is Cindy. What shall I call you? Asking people their preferred pronouns as an example of ways to sort of work around that difference and make sure we're doing things that our practice is inclusive. Looking at whether everything that we do within the workplace, our policies, are fair. And then that last reminder, I think this is a lifelong process. And as we talk about our own work, it never stops. Even if I've been in the business a long time. So one of the other ways that we get better is we sort of not only watch our bias, but we watch subtle ways in which we do what are called microaggressions. Microaggressions are kind of defined as those ways we act on bias or prejudice that we're not aware of, that come out in little ways. Bill talked about learning by reading social media, blogs, essays, sort of even before you get to work, I'm going to do my work. I know I'm working with this population, or I know the people in my workplace come from this religious background, or I know got people with certain disabilities. I'm going to do my work, watch documentaries, do other things. Be willing to have the conversation, but to be realistic about those. To say, is it all up to this person to educate me? What would that conversation look like? And then the last bullet just says kind of consistently developing our awareness. If we're aware, the example I always give, and I can do this again because I'm male, is men talking over women in meetings. I've got 5 women and 2 men in this room, and I'm guessing some of the women know exactly what I'm talking about, where someone is making a point and the dude is going to cut you off or whatever else. And I just, it is about power and imbalance, and it's about maybe ways that we're socialized around gender, but I just, that kind of, what is it, mansplaining and talking over people, I'm smiling because I just had a very difficult, we were all on a webinar, and I called this dude out. I was like, I almost said his first name, Mr. X, because I don't want to say his first name. Mr. X, she wasn't done. Like, we're all professionals, but it was just, he's so smart and he's so whatever, and he's male and he's white and he has privilege and he's in an academic thing. And I just thought, you know what, I'm going to call out. I said, dude, she wasn't done. I was nice about it, but I stopped what we were doing and I said, she wasn't finished with her thought. And it was like, afterwards I apologized to him. It's like, I didn't mean to be rude, but I felt like that's a way that we say, no, she doesn't deserve to be cut off by you. So again, social justice, back to what we talked about, the view that everyone deserves equality. Again, why are we here? The whole point of looking at these macro level issues, social justice. That bald white guy had a lot to say today. Questions? Let me start in the room. Anything you want to add to the conversation we've had today? Anything you want to challenge? Anything unfinished for people here in the room? Anything you want to take a highlight or two, or any questions I haven't answered?
Jim, a couple of things that
Please.
I wrote down,
Please.
and as you were talking, valuing people, valuing their opinions, I think was the biggest thing I kept hearing.
And again, it's the way we get over us and them, Bill. That if we're in a us-them thing, there's something inherent about my not valuing you. But once we sort of reinforce, and it's back to second or third slide, the inherent value of people, both in nursing and social work ethics, say we embrace the value of people, we're going to overcome that. But if we're not going to come from us, them, but it's something about valuing the individual, the client we're working with, valuing our coworkers, as a leadership team, valuing the diverse employees that we supervise, the diverse people in our constituent group.
And then the other thing I wrote had to do with power and control and willingness to giving up that power and control by saying, I want somebody that's different in this position, or on this board, or representation, or and so that's difficult. You see it in small town, you see it in corporation, you see it in every organization we are. Am I willing to give up a little bit of power to have some diversity and to have a differing opinion?
And thank you, Bill. I think it's human nature. We surround ourselves with people like us. I did a training years ago, and was some kind of, I don't know, team building, something. But this woman, I did a Myers-Briggs thing. This woman had hired other white women that looked just like her, whose values were just like her, and I kept doing these activities. Well, what does everybody think? They, as a group, went with Mama, and as a group, went with Mama over here. And so there is a way that people that think like us, look like us, worship where we worship, that's familiar. But again, we grow as individuals when we challenge that, when we say it's time for somebody else to take a seat at the table. And again, that hard question, do the people in the boardroom, do the people at the leadership level look like the people in the parking lot, look like the people in your lobby? And if the answer is no, I think it comes back to service delivery, and it comes back to public health values. Anyway, I think I got to thank everybody. think I'm done. Am I done? Oh, resources. Oh, you thought Jim was so smart. Oh, Jim's so smart. Jim is so smart. He stole from all these websites. Look at that. Boy, he is smart enough to steal from some good people. Anyway, thanks to I almost said the guys in the booth, the guys and the women who are running the video conference group, Anna's here, to the Alabama Wise Woman program that's provided support. To you guys for coming. Bill, as always, for your help with the CEs and your friendship all these years, and you're making this happen. I'm grateful to everybody. Thank you all here. Thanks to those who took an hour and a half, either from your live day or from your archive day. I know I've asked some hard questions, and I'm really grateful that people took a minute to think about these things. I'm grateful always to be here. So with that, I think Bill's going to close this out.
I am. Thank you again, Jim. That was awesome. The great thing about this program is that the guys in the studio here are going to put this on the internet, and we'll be able to go back and watch it again. And there's some information I want to review, and so thank you for that. And those of you who are watching, please know that that's going to be available in the next couple of days. This concludes our program for today. Again, thank you, Jim, for being here, and thank y'all for watching. Again, you can go to our website and find that information, and please make sure to send in your continuing education information if you want CEUs.